This week on the BackTable podcast.
Or is any potential for resection, or do we even need resection? Some of these honestly are completely cured, as you know, once you look at their PET CT scan, which it brings so much hope to patients and so much positivity despite the fact that they were diagnosed with stage 4 disease. I think that's really important to keep in mind is I do give my patients a break after a certain interval. 2 years is my maximum.
Yeah, that's absolutely right. And then there's some data evolving too that even if they progress or relapse, you could potentially rechallenge them or retreat them with immunotherapy as well.
Right. I've done it in a couple of anecdotal cases.
Yeah,
when I've had
great.
to. When I've had to.
Hi, everybody. My name is Jun Gong, and I'm a medical oncologist at Cedars-Sinai Medical Center. Today, it's an absolute pleasure to have Dr. Cathy Eng here on the BackTable Tumor Board podcast to talk about relevant updates to CheckMate-8HW. And briefly, Dr. Cathy Eng is the David H. Johnson Chair in Surgical and Medical Oncology, Professor of Medicine and Hematology and Oncology, Director for Strategic Relations, VICC, and the Director of the Young Adult Cancers Program at Vanderbilt Ingram Cancer Center. Dr. Eng, welcome to the podcast.
Thank you for having me here.
The reason for this podcast was because there was a highly anticipated release of some updated results from CheckMate-8HW, and I thought we'd get your key insights and takeaways from this recent release, as well as some other relevant topics in MSI-High colorectal cancer as well.
Sure.
So jumping straight into the CheckMate-8HW study, I thought I'd just give a little bit of a backdrop to the audience here. The study design, this was a global randomized open-label international phase 3 trial randomizing IO-naive, centrally confirmed MMR deficient mCRC patients in a 2:1 ratio to the following arms: Nivo plus Ipi, and I wanted to highlight that the Nivolumab dose was 240 milligrams, and the Ipi dose was 1 mg per kg every 3 weeks for 4 doses. Then to Nivo at 480 every 4 weeks. Another arm was Nivolumab, 240 milligrams every 2 weeks for 6 doses, then 480 milligrams every 4 weeks for a maximum of 2 years. And the third arm was your control standard of care chemotherapy with or without a biologic. The original study had a dual primary endpoint, PFS by central review of first-line Nivo-Ipi versus chemo, and then Nivo-Ipi versus Nivo, all lines, basically. So that's the unique study design of that. And just to go briefly about the study population, there was 354 patients randomized to Nivo-Ipi combination, 353 to the Nivo arm, and 101 to the chemotherapy arm. Demographics, the majority were white, greater than 80%, and greater than 66% of the population were from US, Canada, and Europe. Greater than 53% were female, and greater than 67% were right-sided tumors. 80 to 85% had centrally confirmed MSI-High or dMMR status, and 24 to 26% BRAF mutant, which is not surprising given the tendency to have coexistence of these molecular phenotypes. The breakdown of prior lines, 57% had no prior lines of systemic therapy, 19% had 1 prior line, and 24% had greater than 2 prior lines. Now, I wanted to go over the initial readout first, Dr. Eng, before we highlight the updated results. So the initial readout, first-line Nivo-Ipi versus chemo, there was a PFS benefit in favor of Nivo-Ipi, not reached for the Nivo-Ipi arm versus 5.9 months. This is an adjusted difference in restricted mean survival time at 24 months of 10.6 months, which is a p-value of less than 0.01, and the hazard ratio for PFS was 0.21. So that was quite impressive when that initial survival curves showed out. And then there was the same superior PFS in favor of Nivo-Ipi in all patients randomized. And then in the all lines assessment of Nivo-Ipi versus Nivo, the PFS benefit in favor of Nivo-Ipi was not reached versus 39.3 months, hazard ratio 0.62, a p-value of 0.0003, and then the same superior PFS in favor of Nivo-Ipi versus Nivo in all patients randomized. And going over the response rates of this study, overall response rate of 71% with Nivo-Ipi versus 58% with Nivo, 30% actually CR in the Nivo-Ipi arm versus 28% CR in the Nivo arm. And then lastly, I just want to highlight of the initial safety results of the Nivo-Ipi versus chemotherapy comparison, there were 2 grade 5 AEs in the Nivo-Ipi arm versus 0 with chemo. And if you look at the kind of the subnotes, this tended to be pneumonitis and myocarditis cases here. 23% grade 3 to 4 AEs versus 48% grade 3 to 4 AEs with the chemo. And Dr. Eng, if you can backtrack to when those first results were released, what was your initial thoughts and reactions to the CheckMate-8HW results?
When we first got the results, we were quite impressed, obviously. I think we weren't so surprised because we had had some interesting phase 2 keynote data regarding the potential benefit of the combination of Nivo-Ipi together. But I mean, these findings were wonderful. I mean, it's a huge breakthrough for patients. We already knew immunotherapy as a single agent was beneficial, but this really highlighted that the combination of immune checkpoint inhibition and CTLA-4 is beneficial for patients. So it's really potentially changing the field, right? And it's also increasing your chance of being completely cured despite having stage 4 disease.
Absolutely. That distinction in stage 4 and these great results were really impressive. Were there any of the safety concerns for you when you saw the initial safety data for this combination?
I think it just reminds you that you have to be careful with this patient population when you're considering, even for single agent IO therapy, there are potential toxicities. I think it just really reminds you to check in on your patient frequently, even though they don't really necessarily have to come in all that much, given the schedule, and just be cognizant of potential issues with pneumonitis.
Does that automatically change your approach to some patients based on comorbidities of who you would choose the doublet versus the single IO, for example?
For me, I look at the patient to determine, are there symptoms that they're having? Is it attributed to the tumor itself? Or their performance status is complicated and potentially worse because of their other comorbidities. I think those are two different patient populations. When it's attributed to the tumor burden itself, I think it's very reasonable, even if a patient appears to have a PS of 2, to give the combination for Nivo-Ipi in that setting if we believe it's truthfully due to the tumor burden and they're otherwise healthy. I think if you have an individual with multiple comorbidities, you do have to put some thought into it and think about, is it worthwhile considering the combo therapy versus single agent therapy? I think you do have to be thoughtful about that. I do want to mention that, myocarditis is not common. I mean, it's not frequent at all by any means. I've only had one case, but I'm sure there are other cases. People may have reported a few others, but pneumonitis obviously is a little bit more common, such as colitis as well too. So just to be more thoughtful about your potential toxicities.
No, of course, of course. And you've been a really great proponent about realizing often that the patient-physician relationship often also involves barriers such as geographic barriers. You have some patients in your region that may travel really far away. And I think this applies to many places across the country, actually. So in a patient like this, what type of motivation does it take a patient? Do you want them to call you, check on you, or you check on them very frequently? And then the logistics of travel, if they do have an IRAE, does that play into your factor of how these regimens are decided?
That's a great question. You definitely want the patient to communicate to you. I really emphasize that early on, whether they just send a brief message through the patient portal just to let us know that they're not feeling so great that day so we could follow up. I think that's really important. I mean, obviously, access is an issue. I have several patients that drive in for their treatment, but keeping in mind that they don't necessarily have to come that often as well, right? Because once you do the Nivo-Ipi and then do the maintenance portion of Nivo, I mean, they don't have to come all that much, right? Versus being on standard chemotherapy. But I do make patients aware that it's not that immunotherapy is not toxic. It just has different toxicities than standard chemotherapy. And I think that's important to keep in mind. But yeah, no, patient communication is extremely important. And you cannot overemphasize the importance of that because you don't want to miss a severe colitis and just presume it's just due to diarrhea versus a reactive airway disease or I've got a cold and find out it is pneumonitis.
Absolutely, absolutely. So that was some great initial takeaways, Dr. Eng. We'll jump right into the CheckMate-8HW update. This was presented at ASCO this year. So now we have a median follow-up of 55.1 months in all randomized patients. And this was basically a post-hoc analysis of the CheckMate-8HW. They found that of the patients that alive more than 4 years after treatment initiation, 54% were in the Nivo-Ipi group, and this was higher than the 45% in the Nivo group. And then they kind of stratified overall survival by best overall response. So not surprisingly, your best OS was when you had a CR or PR, and it was actually not reached in both the Nivo-Ipi or the Nivo comparison. If you had a stable disease, you still did better with Nivo-Ipi. It was not reached versus 26.8 months OS if you had stable disease for Nivo monotherapy. By progressive disease, it was pretty much similar, 12.5 months in Nivo-Ipi versus 13.5 months in the Nivo comparison. They presented some interesting overall survival breakdown by liver metastases. So if you had the presence of colorectal liver metastases, your hazard ratio was in favor of Nivo-Ipi at 0.62, but this did cross the 1, again, on a post-hoc analysis here. And then if you did not have liver metastases, your hazard ratio was better, 0.57, in favor of Nivo-Ipi as well. There was a similar pattern for PFS by best overall response rate in favor of Nivo-Ipi. And I think the more interesting results that they showed was this treatment-free interval that they were able to present. It was 29.7 months in Nivo-Ipi versus 20.9 months in Nivo. 32% never received any subsequent therapy, and 30.6% never received any systemic therapy with Nivo-Ipi. And the number of long-term survivors was 32.9 months versus 31.7 months. They did look in to see were there any defining qualities or characteristics between the long-term survivors, and there was no defining characteristic in long-term survivors versus all randomized, centrally confirmed MSI-High patients. So these patients, again, as part of the design, they were able to be treated up to a maximum 2 years, and to see some of these patients have treatment-free intervals, I think was rather interesting. So I wanted to get, Dr. Eng, your initial thoughts on this longer CheckMate-8HW update.
No, I think, once again, validating their earlier findings, it's really critical. They had long-term follow-up, and I think it's fantastic. I mean, it really justifies the combination of Nivo-Ipi for benefit to our MSI-High patient population.
Does this new treatment-free interval data help your selection for patients of Nivo-Ipi?
I think it basically reinforces the consideration of utilizing the combination of Nivo-Ipi. When you're having that discussion with the patient about the potential toxicities, and of course, there are going to be some patients that, may not feel so comfortable because there are potential toxicities for the combination. But that would help maybe give them a little bit more positive reinforcement about how to move forward with that combination. And also, keeping things in mind that this is for a short period of time. They're only going to do Nivo-Ipi for a defined period of time. It's not like they're going to be on it for forever.
That's right. And in your experience, do most patients get through the induction of the 4 cycles of Nivo-Ipi?
Yeah, I haven't had, knock on wood, I haven't had an instance yet where I've had to stop it. But yeah, I haven't had anything significant that, I don't think I've had a patient that's regretted doing Nivo-Ipi combination at this time. Of course, I've had some rare instances where, you have the development of type 1 diabetes, or I had one case of myocarditis, but those are few and far between.
Yeah, no, same here. In our experience, everybody gets through the Nivo-Ipi induction and they move on to that maintenance Nivolumab. So when in these patients, they're showing that about 30% of them will get to CR, and based on this TFI treatment-free interval, a significant patient will make it to that 2 years. Do you, Dr. Eng, stop at 2 years? Granted, this is a stage 4 kind of population, but do you stop at 2 years, or how do you decide?
Yeah, number one, I do at least a full year. And then depending upon the patient, I may reevaluate them sooner to consider stopping sooner. But yes, 2 years is pretty much my maximum. We restage all patients with a standard CT scan. And if feels as if they're heading towards a CR, then I'll get a PET scan to rule out what's active disease versus fibrosis, or is any potential for resection, or do we even need resection? Some of these honestly are completely cured, as you know, once you look at their PET CT scan, which it brings so much hope to patients and so much positivity, despite the fact that they were diagnosed with stage 4 disease. So I think that's really important to keep in mind is I do give my patients a break after a certain interval. 2 years is my maximum.
Yeah, that's absolutely right. And then there's some data evolving too that even if they progress or relapse, you could potentially rechallenge them or retreat them with immunotherapy as well.
Right.
So
I've done it in a couple of anecdotal cases
yeah,
when I've
that's
had
great.
to. When I've had to.
Now, this is more of a tangential question, but it may relate to just immunotherapy administration in general. You may recall there was a study that showed a effect of administering immunotherapy in the earlier sessions of the day, perhaps in the morning, and then that may be better than the later times of the day infusions, and they tend to do better in terms of outcomes. It's been controversial because one of the Nature publications that actually reported on this ended up being retracted by the editors because of concerns about just some integrity of the data. So I think that the jury is still out there, but I wanted to just get your quick thought on that. Is this a phenomenon that you practice at your institution?
We do not.
Okay.
As you know, chair time is hard to find for patients, and to try to utilize certain chair times for only the IO patients is really tough when you run an academic institution where there's a lot of other clinical trials. So I would also agree with you because the data was not, it was intriguing, but it needed to be validated. And so currently I do not utilize that concept.
That's great to have your input. We same here at our institution, and many that I've also talked to, they don't implement that early the day infusion. I think it's also important to point that out there because some trials are beginning to amend their protocol to consider early infusion administration of IO based regimens. So I think it's very important that we get your word out there too, that this is still a very controversial area to even integrate into routine practice nonetheless in these clinical trials as well.
It definitely needs to be validated. I would say that. I would not put it into my daily practice by any means.
Gotcha. Great. So we talked about this was really a chemo-free option of Nivo-Ipi or Nivo versus chemotherapy. I wanted to get your thoughts on the COMET trial, the commit trial, basically. And briefly, the study design this was a prospective phase 3 randomized open label trial, first line MSI-High MCRC. This was originally 1:1:1 FOLFOX-Bev versus Atezo versus FOLFOX-Bev plus Atezo. But after Keynote 177, commit closed the FOLFOX-Bev arm, and then accrual was then suspended in March of 2025 due to the CheckMate-8HW trial. And so it was down to a smaller subset of 41 patients with FOLFOX-Bev Atezo versus 41 patients with Atezo, so likely underpowered, but the results were presented, and the demographics, median age 61 versus 64, 17.1 versus 19.5% with liver metastases, so a smaller population of what we expect. 22 versus 24% BRAF. The majority, 70 to 73%, depending on the arm, were right-sided and transverse colon primary. And these were the primary endpoints readouts. The median PFS was 24.5 months with the chemo immunotherapy arm versus 5.3 months with the Atezo monotherapy arm. The hazard ratio was 0.439, p-value of 0.01. And the secondary endpoint overall response rate was 86.1% versus 46%. There was 36% CR rate versus 18.9% CR rate in favor of the chemo immunotherapy arm. Toxicity was higher with the chemo immunotherapy combination. Grade 3 to 5 AEs, 83% versus 44%. Grade 5 AEs, 9.8% versus 2.4%. And then just a little bit of the context, Keynote 177 monotherapy PFS was 16.5 months with Pembro. And then we discussed the CheckMate-8HW PFS curves. So What were your thoughts on the atezo monotherapy arm performance in this study?
I have to say that shocking, but I think would
Mhm,
be a
mhm,
appropriate way to describe it. We were all completely surprised by the results of the monotherapy arm, given the prior results of Keynote 177 and given the results of the Nivo alone arm in CheckMate-8HW.
mhm.
This was completely suboptimal. Granted, it was completely underpowered, but really concerning regarding the monotherapy arm.
But is there anything we can take away from the commit study? Is there any patient, for example, you could envision using chemo and immunotherapy in an MSI-High MCRC patient?
I would have to say no.
Okay.
I would not recommend it, obviously, given the toxicities. This study, unfortunately, and there was so much time put into the study. I remember when it was originally written, and it's very unfortunate when you have a trial that's been written several years ago, and it took a while to enroll to, and then you have other studies that have come out in the interim, and then you close your study prematurely because it takes a lot of time and commitment, as you know, to open any trial for that matter, regardless of the phase, but especially a phase 3 trial, which involves multiple sites. It's usually an international study, right? So I would definitely say this would not be a recommendation that we can utilize in any setting. I would not recommend it in any setting.
Got it, got it. No, that's a point well taken, and I think you highlighted how difficult it is for such a study to be designed and accrue over the years. But I think there's a the investigators do deserve praise. I think they appropriately closed
Mhm,
accrual when these new results came out, and I think that's
definitely.
a learning point for a lot of us in that sense.
I think it was very smart of the lead PIs and the company to close it when they saw that it was not appropriate to keep enrolling patients given the current environment and the current
Mhm.
findings from other studies.
Yep, yep. We talked about chemoimmunotherapy, the Nivo Ipi arm. Are there patients you would still choose a monotherapy IO in stage 4 MCRC?
I would say I think it's if you have an elderly patient that has lots of other comorbidities, I may think twice about utilizing the combination of Nivo-Ipi in that setting. But I think, once again, if the majority of the patient's symptoms and their performance status are compromised by the tumor itself rather than their other comorbidities, I would favor combination therapy. However, if there's multiple comorbidities and the patient may be frail, I would really then consider single agent, I would think.
Gotcha. And then you hinted there too, if there is a lower disease burden, for example, those maybe lymph node only metastases, is that another population where you would consider monotherapy, or it's mainly on comorbidities and frailty?
Honest for me, that's what my decision would be based upon. Not necessarily the location of the tumor, but how the patient is feeling overall and how well they will be able to tolerate the treatment.
Great, great. So, Dr. Eng, thank you for giving us your high-level insight on CheckMate-8HW. In more of a broader question, in a patient with first-line MSI-High MCRC and BRAF mutant stage 4 MCRC, what are you choosing, breakwater or the immunotherapy-based combination?
That is a great question. So we're talking about our BRAF mutant MSI-High hypermethylated patients. In those patients, I choose IO therapy as my first choice versus going with breakwater with a BRAF inhibitor. So my choice is always IO therapy in that setting. The CMARC trial has completed enrollment, and it's specifically looking at this question in regards to a BRAF mutant MSI-High patient population. So I'll be looking forward to those results.
Perfect. And so I like to finish off with just you were returning from ESMO GI. Were there any high-level impressions or any key findings you wanted to relay to the audience, the BackTable audience from ESMO GI?
Well, I think the one trial that was disappointing, unfortunately, was in the KRAS G12C second line patient population. The adagrasib data with Crystal 10, I believe is what it's called, was a
Mhm.
negative study looking at adagrasib plus EGFR therapy in the second line setting. Even though we know adagrasib is already approved in the refractory setting, I think, it'll be very interesting to see if there is improved activity with the KRAS G12C inhibitors in the frontline setting for metastatic colorectal cancer. I'm hoping that will be the case because there's some very interesting data in combination with chemotherapy that's been presented in the past. I look forward to seeing some of that data, but I would say that's the one trial that really stood out to me that unfortunately was a negative trial.
Yeah, no, that was a big shocker to us too, given the excitement for the RAS inhibitors, especially. With that being said, Dr. Eng, it was an absolute privilege picking your brain, and I know that this podcast will be of tremendous benefit for providers, healthcare providers, and the broader BackTable audience. So, on behalf of BackTable Tumor Board, I thank you so much for joining us today to discuss these updates on CheckMate-8HW.
It's my pleasure. Thank you so much.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles, John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.